We all know the train's left the station. Is it indeed on the right track? And here's the approach that we'll take. I think it's important to begin with a bit of a background just to put things into context. Then I'll go over the current pivotal trials, talk about some studies that are in the developmental stage right now, go over some potential TAVR applications that aren't being used right now but probably are on the horizon, and then talk about the impact on clinical practice. And that really is why I think it's important to have a talk devoted to this, because TAVR is going to have an impact on our clinical practice. What might that be? Okay, so let's put this in context and talk about the background. So, this is not advancing there we go. The time TAVR came out, we were doing pretty well with aortic valve surgery. Here's a summary article about conventional aortic valve surgery in a prestigious journal. And we saw that, number one, the volume was increasing. Secondly, the complications were decreasing. So an already great operation was even doing better. And then the transcutaneous valve procedures were just kind of rumors. We did recognize, though, that there were patients that were out of bounds for surgery, too high risk for surgery. Could something be offered to them? And that's when the Partner B trial came out. This is a study that looked at patients that were too high risk for conventional valve surgery, and the question was asked, well, could TAVR, this transcutaneous aortic valve replacement, afford them any benefit? So it was an inoperable cohort. They compared TAVR to the medically treated patients. TAVR gave better mortality, it gave better benefit. At a year, the stroke rate was higher with TAVR, but of course that was because you're doing a procedure on somebody, and the medical patients didn't actually have a procedure. So that was followed then with the Partner A trial. And here we looked not at medical patients, but we looked at very high-risk patients treated with conventional surgery compared to those who underwent TAVR. So a high-risk cohort, the survival was similar in the two treatment groups, as was the benefit. And there's really no difference in the stroke rate. A bit debatable there, but essentially no difference in the stroke rate. And at this point, we had a couple of first-generation devices out there, and I think most surgeons, probably even most cardiologists at that point, thought, well, this is something that might catch on a little bit. Well, kind of caught on. The floodgates truly were opened, and we know the acceleration of pace of the use of TAVR since then. Now, the pace in Europe was a little bit concerning, because that was done primarily by cardiologists. Some surgeons participated in the procedure, to be sure. But it had kind of run amok in Europe. And we wanted to make sure that in the United States we had what was called controlled rational dispersion of the technology. And with the backing of CMS, with the backing of FDA, we came up with this TVT registry, which was sponsored by both the Society of Thoracic Surgeons and the American College of Cardiology. This gives you a feel for the timeline associated with it. It was December 2011. And we first rolled out the TVT registry, and it really has an impact. Virtually all the patients that receive a commercially available valve are receiving this device. Formal structure to the TVT registry with, importantly, a stakeholder advisory group that has both patient advocates, industry, and a variety of other stakeholders as well participating. A ton of information is gathered on all the patients that are entered into the registry. This is one of 7 pages of dense data that are interested in one of the complaints about the registry, as you might imagine. A variety of outcomes are monitored to include long-term outcomes as well as 30-day and 1-year outcomes. The long-term outcomes are obtainable by a link with CMS data. So this allows us to get things like reintervention rates, survival rates years down the road, and readmission rates, that type of thing. This shows the rate of increase in the number of patients that are entered into the registry. Right now, there are over 53,000. And again, this is virtually all the patients that have received commercially available TAVR procedures in the United States. Just to give you an idea of the fact that it's pretty much spread across the country. This slide I put in because I wanted to emphasize a point that FDA strongly endorses the use of the TVT registry, and they're using this real-world information in the registry in a way that has not been used before in a regulatory agency. As you might remember, the initial SAPIEN valve was approved only for transfemoral application. Well, everybody recognized that non-transfemoral / alternative access was invaluable to patients if you couldn't gain access through the femoral route. And so ACC and STS got together, and we were planning what's called an IDE study to expand the indications on the use of the device. And these are very rigorous studies for anybody that's ever participated in them. IRB approval, patient consent, rigorous statistics. They're expensive, they're time consuming. And right at the time we rolled this out, FDA just said, okay, that's enough. We know that we're going to be able to get 10 times the number of patients in the TVT registry. We know that they're going to be real-world patients rather than this selective patient population you're going to have in your randomized IDE study. So we're going to use information directly from the TVT registry to determine whether device expansion is indicated. And sure enough, they said, yeah, it is. Expansion of these indications is indicated to alternative access, and that was the end of that. So I think it's important to recognize this. This is going to be the wave of regulatory studies in the future. And so the ability to use this in an approved way was 3 years ahead of its time. If we'd gone through the IDE, we'd still now be working on it. So what kind of pivotal trials are underway now? I've talked about a couple of the initial pivotal trials. We've got the Partner 2 Cohort A study that's out now. And here we're going down, remember initial partner study looked only at the high-risk patients in comparison with surgery. Now we're looking at the intermediate risks in comparison with surgery. And this just gives you an idea of the comparison of the patient characteristics between the TAVR and the surgery groups. And here are the 2-year endpoint results. The composite endpoint was stroke and death. And you see that TAVR was favored at all phases in that first 2 years. Clinically insignificant and statistically insignificant differences. Importantly, you look at the aortic valve area here, and this also favors TAVR. For the core valve, we've got 3-year outcomes now. This was just reported at ACC a few months ago. And we see that back to a high-risk group that you had results showing the mortality, again, favored TAVR at 1 year, at 2 years, and at 3 years. And this shows both mortality and stroke in the core valve study. Notice the last row there where we talk about the mean aortic valve gradient. That's really key. That is really key. And it looks like you're able to get in a valve that is going to be larger diameter and therefore be associated with lesser gradient using the TAVR procedure as compared to conventional aortic valve surgery. For those that are into curves, here's what those 3-year results look like for the core valve procedure. Both the composite and individual mortality and stroke rates, all favoring TAVR. Vino Thrani has now got a paper in Lancet looking at the SAPIEN 3 1-year results. This is an intermediate risk patient population. Not a randomized control study, they use propensity matching. And you see the results there, once again, favoring TAVR. Well, what do we have that's in the developmental stage? That's what's out there right now. And of course, what are we going to do? We're going to go look at the low-risk patients. The Partner 3, the Evolute-R studies, both will examine this population. Strap on your seatbelts. I'm not sure what we'll find on that. Elective valve and valve procedure, this really has started to take off now. In 2015, it was approved by FDA, and by valve and valve, I refer to a bioprosthetic valve that was surgically placed that has failed, and you use a TAVR device to put a new valve through that old annulus that had been surgically placed. And you see that's already starting to take off now. Well, what potential TAVR applications are out there? We've already talked about the valve and valve. That it's not so potential anymore. It's being used, and I expect that we're going to see a significant increase as time goes on. How about aortic insufficiency? All the studies that we've had up to this point have been on aortic stenosis, critical aortic stenosis. How about aortic insufficiency? Logic would dictate you're probably going to be able to get pretty good results with those as well. How about moderate stenosis? Again, we've looked at critical aortic stenosis up to this point. Will the patient with moderate stenosis also be a candidate for this? And all the patients in the pivotal trials, at least, have been symptomatic. How about the asymptomatic patient with critical aortic stenosis? We're not real sure what to do with those even before TAVR came out. Now it looks like we might be able to offer a lesser invasive procedure should we shift the curve to account for the possibility of maybe saving these asymptomatic patients problems down the road. And lastly, patients at low risk for surgical aortic valve replacement. We'll be looking at that with the randomized trials coming up very shortly. So what kind of impact is all this going to have on clinical practice? Now, I think to really answer that, we've got to look at a few trends that we see taking place with TAVR as it's been applied in these last few years. Age difference in the TAVR patients not really changing that terribly much. Going down a little bit, but not that much. On the other hand, if you look at the risk of patients undergoing TAVR, you see that's a pretty significant drop-off in the calculated risk. Bear in mind, now this is risk that's calculated based on the STS model, which is designed to predict operative mortality after surgical conventional aortic valve surgery. But the risk is going down in the TAVR population, as is the mortality. Mortality rates are getting better. Is that because of the patient population and the fact that they're treating patients at lesser risk, or is it because the procedure is getting better and the new generation of devices has improved? Stroke rate really hadn't changed that terribly much. Where's the procedure being performed? Well, more and more we're seeing the procedure performed in the hybrid ORs. Let's go back. And the disposition, more and more patients are ending up going home as opposed to a nursing home or a rehab center. So you put all that together, and we still don't really have a firm answer. Before I draw some conclusions here, I'd like to briefly mention, though, that we do have a new risk calculator out. I mentioned that the STS model, which has been used to assess the risk of TAVR up to this point, has pretty much relied either on Euroscore or the STS score. And neither of those are designed to specifically predict the risk of TAVR. Now we have an instrument that allows us to do that. And I think this is going to be a real advance. The risk calculator is out now as an app. It'll soon be on the software that's in the TVT registry. And it relies on 9 different variables that can be entered by the user. So you get a predicted risk of in-hospital operative mortality for the patient at hand. We're already at work on a risk model for stroke and another risk model for 30-day mortality. So what kind of general observations can we make as we try to reflect how this is likely to impact our practice? Well, TAVR results are improving. The indication creep is slow, but it's present. We can see it, and there is probably reason to believe that it's going to accelerate. I think we have to accept the fact that the gradients that you get when you put in a TAVR device are going to be better, as a rule, than what we have with surgical aortic valve replacement. And those of us who tried to wedge in little 19 millimeter valves recognize this. AI, still much more common in TAVR than SAVR. What are the results of that going to be long term? They're not going to be good. But the other side of this coin is that significant AI in TAVR does appear to be decreasing with time as the devices get better and as expertise in putting the devices in gets better. The durability of TAVR is not well established. Can we conclude that the longevity of a TAVR device is going to be the same as a surgically placed bioprosthesis? Jury's still out on that, and I think we need to keep that in mind. And I think we have to conclude the evidence right now indicates that both in the high and the intermediate risk, TAVR is very close to SAVR in operative results. And if the results are closer, then logic would dictate one should strongly consider going with a lesser invasive procedure. So where to from here? Some would say that surgery is now going to be reserved for pretty specific cases like endocarditis, those patients who also need a coronary bypass, those patients that also need a mitral valve at the same time as surgery. Not sure I would go that far, but you've got some pretty prominent names in thoracic surgery that take that position. We talked about the survival of bioprosthesis. Is that equivalent to what you see in a TAVR device versus a surgical device? How about the survival of bioprosthesis equivalent to mechanical valves? Another question that has to be answered. And certainly we do need more information on long-term durability. So questions still to be answered. I'll throw this presentation out as an overview for the next couple of talks and look forward to the question and answer period. Thanks for your attention.